speak on vascular access in CRRT. And in the next 45-50 minutes or so, I will try to go through some of the salient features of vascular access that we do in CRT. And during the conversation, I will try to build up some or bring up some common scenarios that we may face and how we can possibly resolve these scenarios. And of course, having said that, we all understand that vascular access is a very challenging issue, and different patients may require different strategies. So before I go on, these are my disclosures. Right, so this is just the outline of my talk. So as you can see, the center of this talk is actually going to be on vascular access. And any one of us who has put in a vascular access may be very familiar with this picture that I have drawn to depict a vascular access. So we all know that access, you can basically divide it into three major parts. One is the part that stays outside of the body, through which you insert your guide wires and through which you access blood from the patient. So you have an access or an arterial port and a venous or a return port. And then this has a length of which can vary from anywhere from about 15, 16 centimeters to about 24, 25 centimeters. And that is essentially the shaft of the vascular access. And then the most important part of the vascular access, which is basically the part where all the action happens, is essentially the functional tip of the vascular access. And this plays a very, very important role in the integrity of the CRT that we will perform on these patients. And of course, this access is anchored to the skin by the hub, which has two ports, two holes through which we can put in the sutures to anchor the catheter. Some of the things that we will go through in discussion will be, of course, how do we choose the catheter, the material, the catheter's shape in terms of the lumen and the tip, the catheter size and diameter. We can choose the site for the insertion of the dialysis catheter, which vein would you choose if you had the luxury of having all possible accesses available to you. What would be the length of the catheter then you would choose, if you are depending on the vein that you have decided to cannulate. The insertion technique, what if there are multiple catheters in the same vicinity, whether in the same vein or in veins wherein they all meet into the central vein. Once the catheter is inserted, how do you maintain this catheter? And then, of course, some complications of dialysis catheter, which may be related both to the insertion technique, to the presence of the catheter in the endovascular or in the blood vessel, and to access recirculation. And then very lastly, some words on how do you integrate this with extracorporeal ECMO. So for access of for the performance of CRT, we are very familiar with this extracorporeal function of the CRT machine, wherein we know that, we have a blood flow, then the blood flow is passed through a hemofilter, and then we have certain flow rates of dialysate and replacement fluid and anticoagulation running. We fix up a very nice dose of CRT. We've been planned our anticoagulation strategies. But the most important part of CRT is to do that. First and foremost, we need blood to exit from the patient's vasculature into the CRT. And once this blood has been processed by CRT and sort of cleansed by CRT, this blood needs to be returned into the patient. And that single tiny thin tubing that connects this extracorporeal circuit to the blood vessel is actually the vascular catheter. So it is immediately apparent that how important is this tiny bridge that connects the whole extracorporeal circuit with the intravascular compartment. So in any situation where there is either access or a catheter failure, which means that we are not able to sustain a required blood flow through the catheter, and therefore we cannot run the CRT, or even if there is a catheter dysfunction, wherein we may access the blood flow, but the blood flow is very interrupted, the CRT may still run, but of course the efficiency of the CRT will be severely compromised any one of these scenarios, it is very apparent that we will not be able to deliver a good CRRT with the desired efficacy of the CRRT. And this has actually been shown in studies that when they have looked at the causes of failure of the filters or filter clotting, and they divided them into three categories of early clotting, which happened within less than 12 hours, filters that lasted 12 to 24 hours, and filters that lasted greater than 24 hours. And they were around 35% each, in 1/3 in each category. But what they realized, as you can see on the picture on the left, that in those filters that clotted early in less than 12 hours, the access pressure was relatively much more negative than compared to filters that lasted for longer. And the variability in the access pressure, as you can see the line, there's a lot of up and downs in the line that happened, which was signifying that this was a very dysfunctional access. And both of these led to an early filter clotting and loss of the CRT hemofilter. And therefore, we know that the access per se will affect how you deliver the CRT and to a certain extent your CRT filter life. Now, what we generally get aware about is when the CRT alarms or the access pressure alarms on the CRT goes off. And by the time the alarm goes off, we know the access pressure is very, very negative, and in all likelihood, your blood pump may have stopped and the blood flow may be interrupted. But we know that when we are using peristaltic pumps for CRRT, there can be multiple flow reductions that happen in the pump. Now, these flow reductions may be significant enough to compromise the flow, but may not necessarily be significant or prolonged enough that they trigger a CRRT alarm. So this was a very elegant study wherein they interrogated the access flow into the tubing using an ultrasound Doppler. And they identified that 25 of the 27 filters studied, they had flow reductions that they could demonstrate based on this ultrasound Doppler. And there were 314 events of blood flow reduction in 525 hours of monitoring, which means at a rate of almost 0.6 event per hour. And flow reductions of greater than 67%, that means whatever was your flow rate prescribed, if you had a flow reduction of greater than 67% of that, this was closely associated with blood stopping and alarm trigger. And 45.5% of these were moderately severe reductions, that means between 34 to 66%. And though they did not trigger any alarm, but there was a strong inverse relationship of these flow reductions with filter lives. So a lot of times, these invisible flow reductions may be happening that may not be significant enough to trigger an alarm, but they are actually happening if you do not have a very good access, and they are directly, they are related to the filter life. And many times, for no apparent reasons, if we see our filters are clotting early, this is something to keep at the back of your mind. So when you have a patient with in your ICU who has developed AKI, and you have made the decision that you're going to commence this patient on CRRT, the first and foremost step that you will have to do is to establish a vascular access. So as a critical care physician or a critical care, what are the options that are available to us? So of course, in most of the ICU patients who are kind of catheter or dialysis naive, we may need to establish a new access, which generally is established by a non-tunnel, non-cuff catheter. And most times, if the duration of dialysis required in this patient is less than 2 to 3 weeks, we get away with these catheters. But in some patients with AKI, where we anticipate that the recovery may be delayed or maybe not happening in the immediate future, then we should be planning for tunnel cuff catheters. There would also be, of course, scenarios in some patients who are already on an extracorporeal therapy like ECMO, And if these patients need to be commenced on CRT, we have the possibility of integrating our CRT circuit with the ECMO circuit with some kind of standardized connections, if I may say so, currently, which I will discuss at the very end of this lecture. There have been some reports where patients who are already known end-stage kidney disease using an AV graft or a fistula, these can possibly be used for CRT in these patients for short periods of time. But of course, these are not the routine, not in routine usage, and there are very few centers who have published, especially the Center for Michigan, who has published their experience with the use of AVF and AVGs. We have used that in a couple of patients, but we do not use it very regularly, and of course not for prolonged periods of time. And one of the reasons why we sometimes do it is because we have the availability of plastic cannulas or needles, which we use instead of the metal needles in these patients. And we, of course, insert them under ultrasound guidance to use that. But of course, this is not routine use, and I will not be speaking about this anymore than what I have. Now, access, like I have told you, is that link that connects your extracorporeal circuit to your patient's vascular compartment. And therefore, it is very, very important that you take your time and make your assessments and get a good, proper vascular access. Because if you do not have a good access, no matter how good and precise your prescription, how good your anticoagulation strategy, it is very likely that you will run into problems of performing a proper CRRT, and you will be troubled with multiple interruptions and alarms. So when we are making a choice for an access for success, there are a few things you need to consider. One is, of course, the choice of your vascular catheter in terms of material, in terms of the lumen shape, in terms of the shape of the functional tip, the diameter, the size, the length of the catheter, where you would site this catheter in the internal jugular veins, in the femoral veins, subclavian. I just put it there to make the list complete, but we know we generally do not use these veins. And then, of course, you can integrate them with ECMO. And if once you have chosen the vein, depending on which central vein you have chosen, where do you want to position the functional tip of your catheter in the vein to give you the best flows and most uninterrupted flows through the circuit. And of course, all these factors will interplay with individual patient characteristics, which would include their underlying disease, the anatomy of that patient in question, the thrombogenicity in the patient, the immunosuppression, volume status, and of course your strategies to maintain the vascular access. So all these factors interplay to probably give us a good access for success. Now, in terms of the catheter material, we know there are various factors that influence the choice of the material. So of course you want a material which is thick enough, which has an adequate strength and flexibility. It is rigid enough that allows for easy insertion, but it maintains a certain degree of thermoplasticity that once it is inside the vessels, the body temperature heat makes it flexible enough that it does not damage the endothelium of the cells. It has a minimal thrombogenicity. It is resistant to crimping. It is inability to be dissolved by chemicals, and it has minimal bacterial adhesion as much as possible to minimize the risk of a biofilm formation. And when you look into these, the two of the major synthetic materials that satisfy some of these criteria in terms of their stiffness, the thrombogenicity, and the suitability for indwelling catheters are the polyurethane or polyurethane coated with hydromers. And we generally, most of our non-tunnel, non-cuff catheters or temporary dialysis catheters that we use are polyurethane catheters. And the other material that we commonly use are the silicone catheters. And these usually are materials that are used for tunnel dialysis catheters. Now, the knowledge of this material is also important because in the polyurethane catheters, some of the incompatible chemicals with these catheters are alcohols using isopropyl alcohol and ointments containing polyethylene glycol. Whereas for silicone catheters, some of the incompatible chemicals are tincture of iodine, where there may be a potential degradation with povidone iodine. So when we are doing dressings for these catheters, we would probably want to avoid these solutions. And actually, if you think about it, chlorhexidine would probably work equally well for both these catheters. Now then coming to the shape of the lumen of these catheters. So these catheters are present in various shapes, and the shape of the lumen has an important bearing on the flow characteristics in these catheters. And the best flow which minimize the risk of thrombus formations are flows which are laminar and which are very smooth. And the choice of the shape of your internal lumen has a bearing on the flow rate. So whenever there are very acute angles, there would be increased turbulence. And whenever there's increased turbulence, there is a risk of there's an increased risk of thrombosis. So amongst the various shapes that I have shown here, the more commonly ones used are the double or the double D, which is the third from the top, or the cycle C catheters. And the cycle C catheters probably are probably the best choice because they have no acute angle. Their inflow lumen, you can see, is a bit larger than the outflow lumen. And because generally the walls are a bit thinner as compared to the double D catheters or the double O catheters, they have a small external diameter. As compared, and in addition to this, what would be the shape of the functional tip of the catheters? And the diagram or the picture on the right is showing you the various shapes of the catheters. The more common ones that we are aware of are the tip catheters or the pointed tip catheters, the first two that you can see. And these may be multi-perforated or they can be just pointed tips. And the presence of side holes may induce a lot of turbulence in the flow. That can probably increase the risk. Sorry, yeah, right. The most preferred catheter tip shape is actually the step tip or the shotgun catheter, the one that I have encased in the orange box. And this is a catheter where you can see that there are two lumens which are a bit further away, almost like 2 to 3 centimeters away from each other. And these catheters have been associated with the least amount of recirculation. And if you had the option, and these would be the catheters that are recommended for acute RRT. But in reality, many times we don't have an option of an array of catheters that we have in our unit. And sometimes we just have to make use with whatever catheter that is available in our unit. And then we have to kind of use that the best we can. And once you're you have the option or you're limited by these options, but there are other things you can do to try and optimize the performance of these catheters, which is the next portion of the lecture that we are going to discuss. Now, one of the major principles that governs the flow of blood through these catheters is actually the Poisson equation, which I've highlighted at the top. And as you can see, that in the numerator is actually the diameter or the radius of this catheter raised to the power of 4, right? And in the denominator is essentially the length of the catheter, right? So if you think about it, the two major determinants that will determine the flow or the resistance to the flow to the catheter become the diameter of the catheter. And by diameter, I don't mean the external diameter. What is important in a catheter is actually the internal, the luminal diameter of the catheter and the length of the catheter. So if you just study this equation, if you just double the length of the catheter, you would reduce the flow by 50% just by increasing the length of the catheter. Because if you increase your denominator by 2, you would reduce the flow by half. But if, on the other hand, if you just increase the diameter by about 19%, you will actually double the flow of the catheter. Because increasing the diameter 19%, and when you raise it to the power of 4, will double the flow rate through the catheter. And therefore, you can see how small changes in the diameter of the catheter or the length of the catheter but especially the diameter can have major implications in the flow characteristics of the catheter, right? And therefore, the diameter is one of the main determinant of blood flow. And in practice, most of our dialysis catheters we use described to be between 11 French to 14 French, but in reality, most of us are working between 12 to 13.5 French catheters. And on the table below, I have given you the kind of size of the catheter and what is the outer diameter of the catheter. Now, as tempting as it would be based on this to use the largest diameter catheters possible, but we also need to be aware of the ratio between the diameter of the central vein lumen and the diameter of the catheter. Because once you place the catheter in the central vein, it kind of occupies a certain area of that central vein. And because it does so, and the shaft lies in the central vein, it also kind of impedes the flow of blood within the central veins. And there's some literature to show, and this is especially in cancer patients, that an oversized catheter may cause deceleration or stasis of blood flow and increase the risk of vein thrombosis. So a catheter to vein ratio should generally be maintained less than 0.45. So if you put these two factors into place, you kind of see that for most veins, our catheter size of around 12 to 13.5 French would probably work for most of these veins. Now, this is just another study that actually looked at the blood flow through various catheters, and they have catheters of less than 13 French on the left and catheters of greater than 13 French on the right. And they measured sort of the total resistance of these catheters. That means when they were flowing these catheters, they looked at what was the pressures or the resistance that they generated. So the graphs on visually look very, very similar, but if you look at the y-axis, which is the pressure axis on the graph on the left, wherein the catheters were less than 13 French, versus the graph of catheters on the right, which were more than 13 French, you will see for the same blood flow rate, you're generating far less resistance in catheters which are greater than 13 French. So for example, if you say kind of took a blood flow of 300 and you did a 14.5 French catheter on the right, your resistance or the pressure would read about 160 millimeters of mercury. But if you use the catheter which is less than 13 French, which is on your left, a catheter which was say 12 French in diameter at a blood flow of 300 would have a resistance and read a pressure, increased resistance and read a pressure of about 250 millimeters of mercury. So this is just some studies that actually demonstrated that how changing the size of the catheter will influence the blood flow rate. Now, all this looks very, very nice theoretically, but does it really have clinical implications? So this is actually one of those ad hoc studies that came out from the renal trial that was performed in Australia, New Zealand, way back in 2009, 2008, 2009. And what this study did was it analyzed the use of temporary dialysis catheters, the choice of insertion site, the catheter gauge, and their impact on the delivered dialysis dose in critically ill patients who are enrolled in the renal trial. So based on what they identified, the femoral vein was the first access in almost 2/3 of the patient, and 48.7% patients with femoral catheter were randomized to the high dose arm. That means they got an effluent dose of 40 mils per kilogram per hour. And this high dose arm was independently associated with a 26.3% lower CRT dose being delivered. And when they looked at the catheter sizes, 4.2% higher CRT dose was achieved with a 13.5 French gauge catheter as compared to other catheter gauges. And the high dose arm, like I indicated in the previous slide, had a reduced, was independently associated with a lower CRT dose delivered. So all this theoretical talk of the size of the catheter actually does have kind of bearing in the clinical practice, and this is something that you could carry from bench to the bedside in terms of your choices of catheter that you make. Now, the other thing that we need to remember about catheters is laminar blood flow. So if your blood flow is flowing in a linear channel, it is going to be very laminar with lot of with no or with minimal turbulence. But whenever the catheters they hit a curvature, there is going to be turbulent flow. And whenever there is turbulent flow, the risk of thrombosis increases. Now, why does this become important? This becomes important especially when you are using catheters inserted through a left IJ vein, because catheters that are inserted through the left IJ vein, they actually have to undergo two bends. The first bend is when after you insert, there is a bend that will happen when it enters the IJ vein and then it goes into the central vein, and then another bend when it kind of goes from that central vein into the superior vena cava. Right, and because of these two bends, of course, the turbulence in the blood flow increases significantly as compared to a right IJ catheter, which you can see in the picture here. And then the risk of thrombosis or catheter dysfunction will go up much higher. Now, we also know that the veins and the heart, they are encased in the pericardium, right? And of course, if inadvertently there was an injury or a perforation of these veins, which happens below or beyond the pericardial fold, then it could damage the endothelium and cause bleeding in the intrapericardium, and then it could cause pericardial kind of effusion and or hemopericardium, which would then compromise the cardiac function and cause shock. And therefore, for safe kind of positioning of the tip of these catheters, people have divided basically radiologically also in terms of the various zones for the insertion and tip placement of the upper body catheters. So zone A is the confluence of the lower superior vena cava and upper right atrium, and it is it is best to site the tips of these catheters, especially the ones inserted into the left IJ vein, because you want these catheters to go in, and after they have taken the second bend, you want the catheter to go in a little bit more deeper so that the catheter is sort of lying flush with the vein of the catheter or with the central vein, and so that it does not hit and impinge on the wall of the vein. The zone B is that of the upper superior vena cava, and this is suitable for tips for catheters which are placed in the right internal jugular vein. And actually, even these catheters should probably be at the junction of superior vena cava and upper right atrium. And zone C is it is okay for probably using central lines or CVP lines, but it is not good for dialysis catheters. The second, the angle the tip of the catheter should make with the vein should be less than 40 degrees. So which means it is kind of lying a little bit flush to the wall of the vein and not hitting the vein or the vein wall end on, and therefore increasing the risk of perforation. And therefore, the catheter tip should be placed in as large a vein as possible, ideally outside the heart and parallel with the long axis of the vein, such that the tip does not abut the vein or the heart wall end on. So this is the basic principle of insertion of an upper body central catheter, which could be even a CVP line or definitely which is a dialysis catheter. So when you're making the judgment to introduce this catheter, how do you make this judgment that my tip will come and lie somewhere in the zone A area at the junction of superior vena cava and the right atrium? So there are three methods people have used. So one is the formula method, that means they use the Paris formula to kind of judge the length of the catheter that they should be using for the tip to lie there. Or it could be a topographical landmark, which is based or calculated from a chest X-ray that may have been done before actually the need of catheter insertion arose. And then they calculate the length of the catheter from the midpoint of the clavicular notch and the distance from the up to the carina. Oh, sorry, there's a little bit of typo. I forgot to write it. It is from there up to the carina, and then you add to that the distance from the skin puncture to the sternoclavicular joint. And then if you're using a left-sided vein, then you must add 3 centimeters to that. So the distance is from the sternoclavicular joint to the carina on the X-ray, that distance plus the distance from skin puncture to the sternoclavicular joint. That should be the length of a right IJ catheter. And if it's a left IJ, you add 3, and some people say 4 centimeters to it. And then there's another method that has been described called the intra-atrial ECG guided technique. I have never used this, and I personally do not know how to use this, but this has been described in the literature. The references are as below, and you could probably read into this. And so based on these catheters and these formulas, you can kind of choose the length of your catheter. For the IJ or subclavian, the tip should be at the SVC at the cavoatrial junction. And generally, catheter tips that are more than 4 centimeter cranial to the left atrium, the risk of suboptimal function becomes very high. And if you look at on the X-ray, the catheter tip should be about 3 to 5 cm caudal to the right tracheobrachial angle. And that way you'll probably be in the appropriate position in the vein. There are some studies that have shown that this topographical landmark actually allows more accurate catheter placement as compared to the Perez formula, especially in the non-Caucasian population, in our Asian population. These studies have suggested that topographical landmarks actually are good enough, and they give us a good idea. And then if you're using a femoral catheter, the tip must be in the IVC about 24 cm, and therefore you use a 24 cm catheter. Why is the positioning and is appropriate positioning or a longer and a deeper catheter positioning important? Yes, it is. And like was shown in this study, wherein they compared a 20 to 24 cm 13.5 French silicone catheter targeting the tip placement in the right atrium versus a shorter silicone catheter, 15 to 20 centimeter, targeting the tip placement in the SVC. And when they looked at the filter lives, as you can see in the table, the longer catheters had a significantly longer filter life as compared to shorter catheters. There was a better delivery of the CRRT dose. There was less filter clotting, less circuits were discontinued because of vascular access issues. There was no significant difference between the risk of atrial arrhythmias. This, of course, we are talking of catheters that were inserted as tunnel catheters under the fluoroscopy guidance. So these are just some examples of well-positioned catheters. So you can see the right catheter is in zone A, which is at the junction of SVC to RA. It's a good position. This left-sided catheter flows in very well. You can see very clearly the 2 bends, the first bend and the second bend into the IVC. And this is in zone A line again, at the junction of SVC to RA. And the angle to the vertical is definitely less than 40 degrees. So that's a good position. And this is a corresponding scan that is kind of showing you where the position of this catheter is. On the other hand, you contrast this left IJ catheter, and you can see this is probably lying at the very distal end of zone C or the very beginning of zone D, and it is almost perpendicular to the SVC, and you can see on the scans there. And this catheter, I would not be surprised if I did not have a very good run of CRRT or I had multiple CRRT alarms while running these catheters, because this position to me is obviously a suboptimal position of the catheter, right? So this probably should have been looked into or should be looked into if you are having problems with your CRRT. This is a femoral catheter, and as you can see, the tip is lying very well into the inferior vena cava, and this is a very appropriate position of a femoral catheter. So based on these are the lengths that I have suggested to you. Now, assuming that you had all the veins available, you had a right IJ, you had left IJ, you had femoral veins, how do you make a choice? Which vein will I cannulate? So answers to this can actually be had from the Cathedia trial and the ensuing studies from those trials. So of course, the first study looked at the risk of central line associated bloodstream infections. And if they divided these patients based on their BMI, in patients who had a BMI of more than 28.4, the risk of infection was greater with femoral catheters than IJ catheters. And in patients who had a low BMI of 24 or lower, the risk of infection was greater with IJ internal jugular vein catheters than with femoral catheters. So that would be one consideration. So obviously in very obese patients, you may want to prefer an IG catheter over a femoral catheter. Now, if you compare the functioning of a catheter or the dialysis catheter function between a right IJ, using the right IJ as the comparator, if you compare the performance of a left internal jugular or a femoral catheter in terms of dialysis catheter dysfunction, you can see the left femoral catheters perform the worst if you compare as compared to femoral catheters or right internal jugular vein catheters. So what this suggests is that if I had to make a choice between a left IJ or a femoral catheter, my choice should actually be a femoral catheter. Of course, there will be some other considerations that you have to put into, but between the performance, these two would be the choice. And whether you started off with a femoral and then a jugular, or you started a jugular and then changed to a femoral, and whether you looked at both the risk of colonization or infection or the risk of catheter dysfunction, there was no significant difference between femoral and jugular. And this is another study that retrospectively looked at filter life from the side of the catheter inserted. And as you can see, the left subclavian and on the left internal jugular had the lowest CRRT run times as compared to femoral catheters and as compared to IJ and right or tunnel dialysis catheters as compared to ECMO catheters. So again, the site of catheter insertion and where your tip lies actually matters and has an influence on your CRRT runtime. So in my department, this is a kind of a workflow I have created, and most of my senior residents, when they are doing the planning for catheter insertion, they follow this table. So of course, first thing we always pray and look for if we have an existing vascular access. So which means if you have a tunnel dialysis catheter, maybe for a patient already on dialysis, of course, that is the catheter we use. If they are on ECMO, we integrate our CRT with ECMO. If they do not have a vascular access, then we use ultrasound-guided insertion of a non-tunnel, non-cuff catheter, wherein we will review things like BMI, the presence of surgeries, previous attempts, need for long-term dialysis, what is the emergency of insertion, what's the operator experience, presence of coagulopathy, compartment pressures, etc. And then based on that, we will make our choice. So our first choice is always right IJ. If that can't happen, then the next choice is a femoral. And if that can't happen, then our last choice is actually the left IJ catheter. And then these are some of the remarks that I put forth that in addition to what we have discussed in the last 30 minutes or so. So this is the algorithm that I would use for choosing the site of my catheter, and based on that, of course, then the length and then the size of the catheter and where I want the tip of the catheter to be positioned. And this is basically looking at it. If you look at the various studies, most people use a jugular or a femoral vein catheter in these studies. So once the catheter is inserted, this is of course an invasive procedure, and the process of insertion may be associated with complications. And of course, complications would be an inadvertent arterial puncture, local bleeding, pneumothorax or hemothorax, pericardial tamponade, air embolism, arrhythmias, and in case of femoral catheters, retroperitoneal bleeding. Early complications could be like kinking and malposition, and then later ones could be central vein thrombosis or stenosis, or even catheter infections, colonization, catheter-related bloodstream infections, abscesses, etc. Of course, we can minimize all these complications by adhering to very strict aseptic techniques, using ultrasound guidance insertion, and with proper training and supervision of catheter insertion if it is being done by the more inexperienced or junior staff. Once your catheter is in place, is there any benefit of using a particular locking solution like an antibiotic lock solution or a citrate solution as compared to a heparin solution to either minimize the infection, the risk of infection, or to minimize catheter dysfunction? So this was a study that was done in about 400 patients of ICU with AKI requiring dialysis. 203 randomized to the citrate arm and 199 randomized to the heparin arm with an intention to treat analysis in in about 396 patients. And they locked the catheters either with 4% trisodium citrate versus heparin as a lock solution. And as you can see on the Kaplan-Meier graph on the right, there was no significant difference in the duration of event-free survival of the first non-tunnel dialysis catheter or catheter thrombosis, catheter-related bloodstream infection, or adverse effects were also not significantly different. And some of the things that have been established that really help with maintaining and reducing the risk of catheter-related complications is, of course, proper hygiene, maximum hygiene and asepsis measures, use of 2% chlorhexidine alcohol for skin antisepsis, and during the catheter care, also hand hygiene, regular inspection, and the dressing changes if there's any soiling, immediate change if there's any soiling or there's any evidence that it may be contaminated, and proper disinfection of the hubs of the catheter and of course the lower locks of the catheter, and they must be properly disinfected before making any connection of the CRT tubing to the catheters. There's no definite evidence for using antibiotic-coated or citrate catheters. I will talk a little bit about guide wire exchange versus resiting a new catheter in terms of their maintenance. And all this is actually just summarized in these 6 points from from the KDIGO guidelines for AKI, which we have discussed over the last 30-40 minutes or so. And this is just a synopsis of what is their recommendations for the catheter use. Now, the other practical question comes is that if I was to put in a catheter, should I be using a double lumen catheter or a triple lumen catheter? And there's always this fear that, oh, if I have 3 lumens, maybe my risk of infection will go up, or maybe my blood flow rates may be compromised in the catheter because the lumen sizes may change a little bit. So this was a multi-center prospective randomized comparative evaluation of dual versus triple lumen dialysis catheters in 485 patients. And during hemodialysis, a median achieved blood flow rate of 267 mils per minute was realized for both groups. So and for CRRT, a blood flow rate of 267 is more than adequate to achieve good flow through the dialyzer. And even if you are doing convective therapies, which are at reasonable convective doses, you should not be in problem at these blood flow rates. And only about 7.9% patients had catheter-related bloodstream infections. And this rate was not different or was not significantly different whether these patients were using double or dual lumen catheters or triple lumen catheters. So generally, if I had a choice and knowing that these patients will require a lot of antibiotics and drugs and vasopressors and this, it is always for me good to have one extra access site if possible. And if I had, especially these patients had no central line or their vascular access estate was really very difficult, then I would probably choose a triple lumen catheter. Now, what happens if catheters, sometimes you have no choice or the veins are used up with a central line, or you have a complicated patient who may need multiple lines? Does having a central or a CVP line and a catheter in close proximity to each other matter? Most of the times we are able to get away with it, but sometimes having these catheters in close proximity, as you can see in these pictures, the ones that are encased in the red lines, these are probably not the most optimal catheters positions to have. Because in a dialysis catheter, the access is taken a little bit, about 2 to 3 centimeters away from the tip. I mean, it's more proximal to the tip. And if your CVP line is entering and ending, the tip of the CVP line is on the close proximity of the axis ports of the dialysis catheter, it is very likely that whatever you're infusing in the CVP line will be directly sucked into the dialysis catheter, and then it will, if it is cleared by dialysis, it will clear with dialysis, or it may just undergo a certain amount of recirculation and may lose its effectiveness. So the catheters on the red boxes, you can see the CVP line tip is a bit proximal, or it is close to the axis port of the dialysis catheter. On the two yellow boxes on the bottom left, you can see the CVP tip is just at around the tip of the dialysis catheter or just below it, which is okay because whatever you return in the CVP would go downstream. The blood returning from the dialysis catheter under force will also flow downstream, and then maybe it will flow the drug away from the access port of the dialysis catheter, and maybe reasonably okay. The best position, of course, would be on the box in green on the right, wherein your CVP tip is much further down than the tip of the dialysis catheter. And here the risk of remixing and recirculation is actually very, very minimal. And is this proven? This has been shown in this case report that was published. So this was a post-cardiac transplant patient whose blood pressure just did not improve despite increasing doses of vasopressors. And they realized that it is probable that whatever they were infusing in the CVP line was just being sucked into the dialysis catheter, and therefore hardly any effective dose was being delivered to the patient. So once they resited the catheters, you can immediately see on the graph on the right, there was an immediate improvement in the blood pressure. And they have also done some animal studies wherein they have sited the catheters in the central and dialysis catheter in the external jugular vein, and then one away, one in the external jugular and one in the femoral vein. And you can see that when the catheters were away in the central vein in the IJ and one in the femoral vein, the requirement of the NORI dose to maintain a certain blood pressure was relatively lower as compared if they were both in similar veins or in close proximity to each other. So if you have no choice, of course, we have no choice. But if we did have a choice, this is one consideration that you can keep at the back of your mind. I probably will take about 5 minutes more, and hopefully I have permission of that time. I know it's about 50 minutes now. So this is another observation that we have to make, that most of the time we associate that if there is a vascular access malfunction, we will be alerted to that malfunction by the CRRT machine alarm, right? And if the alarm goes off, then of course we know. But this case report that we recently published highlighted to us that you have to be cognizant that recirculation may be happening and your CRT delivery may be ineffective, even in the absence of any alarms that would be happening. So this was a lady who had cervical cancer, then she had some major pelvic surgery and abdominal surgery done. So initially, this patient, of course, was hemodynamically compromised, landed up in the surgical ICU after having a right IG catheter, through which she was undergoing CRRT with citrate anticoagulation. And then this catheter had to be resited to the femoral vein. And if you look at the charts on the right, you will see that after a period of time, the urea kind of just plateaued. There was no improvement in urea. The metabolic acidosis remained. It did not improve, but it did not worsen either. And the systemic calcium and the systemic ionic calcium, total calcium and ionic calcium, both began to increase up to the point that the IV calcium replacement that was being given for citrate anticoagulation had to be stopped for a short period of time. And if you look at the ratio, they did not change, the acidosis did not worsen. So this did not tie in with the risk of citrate accumulation. So when I saw this patient, it immediately struck to me that there's probably some degree of recirculation happening. And then, of course, we did the various studies from the catheter, taking bloods from the various ports, and we demonstrated clearly that there was significant recirculation, more than 90% recirculation. And when we went on, obviously it was not because of flow problem, because your machine never alarmed in terms of your access pressure or return pressures. So we thought of an extra lumen or an extra catheter flow, something outside of the catheter. So we organized for a CT, and as you can see on the CT in the right, there is a big thrombus in the IJ, in the inferior vena cava that was present, which was just distal to the tip of the catheter. And so this patient was basically just having massive recirculation and just kept dialyzing the same volume of blood. And this is just a work algorithm that we have to keep in place, that if we identify that our CRT dose delivered or the CRT efficacy is not what we are anticipating or expecting for a certain CRT dose we are giving, there are various factors to consider. And one of those factors are vascular access factors. And if we have ruled out other things, then we should study the vascular access and study for its recirculation, which can be done. And then if there is evidence of recirculation, then we need to figure out what is the cause. Now, if you do have a catheter which has demonstrated recirculation, or maybe your catheter has reached a certain time point where you think you're going to schedule a change of catheter, or you need to change the catheter because of catheter dysfunction, what do? Do you just change this catheter over a guide wire, or do you resite the catheter to a new vein and with a new catheter? So this question was asked and tried to be answered in a systematic review, wherein they compared the guide wire exchange of a catheter versus resiting the catheter to replace the catheter and resiting it into a new vein. And what this systematic review, which identified out of the 150 odd randomized studies, they identified 12 relevant randomized controlled trials of catheter replacement over a guide wire versus at a new site. And as compared to a new site, guide wire exchange was associated with a trend towards higher rate of catheter colonization. It was also associated with trends towards higher rate of catheter exit site infection and catheter-related bacteremia. However, it was associated with fewer mechanical complications as compared to a new site replacement. Right, so this study seemed to suggest that if you did a guide wire exchange, maybe your risk of infection, colonization, exit site may be a bit more. Of course, you would minimize the risk of mechanical complications associated with the insertion of a new catheter. But this study was in very old, 1997. This is a more recent study about a decade ago, wherein again they looked data from the Elvis randomized control trial of 1,500 odd dialysis patient, and they took patients who had guide wire exchange and they matched them with a patient where they resited these catheters. And what they found is that the dialysis catheter colonization rate was not different between guide wire exchange versus a new venipuncture insertion of dialysis catheter, but the dialysis catheter dysfunction was more frequent with guide wire exchange of catheters, 37.6% as compared to 15.7% if you resited it to a new site, which basically means that if you have a catheter that you are intending to resite, especially because of catheter dysfunction, then it may be better to site a catheter in a new vein than just change this catheter over a guide wire. Because by changing it, is likely that in 1 in 3 chances you will not be improving the catheter function any more than what it is, right? So there are again various techniques that are described. These techniques may vary with unit. So this is just a method of guide wire exchange I've taken from this paper, the paper that I just showed you. And this was the method that they used for guide wire exchange. Now in the last minute or so, I will just discuss how you can integrate your CRT circuit into an ECMO circuit. So as we all know, the ECMO has basically 3 segments: a pre-pump segment, which is preload dependent and which has an excessive negative pressure. And this basically should be treated as a no-touch zone. Don't interfere with this segment. The second segment is the post-pump and pre-oxygenator segment, which is a positive pressure segment. And this is probably the most safe zone, because even if inadvertently there was an air leak or something inside, the membrane will act as an air bubble trap and prevent the embolization of air into the return limb. And then, of course, you have the post-oxygenator segment, which is afterload sensitive. And this is the most definitely a no-touch segment for the ECMO circuit. So when you're integrating CRT, you can either run CRT through a separate access, just like in any other patient, or you can integrate it into the ECMO circuit. And these are the 2 very possible connections that can happen. So your CRT access is generally taken from the post-oxygenator, post-pump, post-oxygenator segment. And the CRRT return is always and always done pre-membrane or pre-oxygenator membrane, and hopefully in the post-pump segment. So the diagrams here are probably self-explanatory as to where you would take the excess and where you return the excess. And in the practical sense, this is how we connect it in our ICUs when we are integrating our CRT circuit into the ECMO circuit, whether we are using a MEC or any other form of oxygenator. And these are just some examples. So to conclude, I'm sure we all agree that vascular access remains a challenge. Catheter characteristics, size, and insertion technique have significant influence on CRT delivery. So the optimal material is a biocompatible material like polyurethane or silicone. Optimal size is between 12 French to 14 French. Optimal shape is a cycle C catheter. Optimal distal or functional tip is a shotgun tip catheter. Optimal length will depend on the vein that you site your catheter in. So it's a right IJ is a 15 to 16 cm, left is a 20 cm, and femoral is a 24 to 25 cm. Optimal site, right IJ, femoral, number 2, left IJ is a third choice. As far as possible, please avoid subclavian veins. The insertion must be under ultrasound guidance with proper aseptic techniques, with proper hand hygiene and aseptic techniques. We must always check the position with a chest X-ray, and resiting a new catheter to a different site may be preferred over a guide wire exchange of a new catheter, especially if you're doing it for catheter dysfunction. And of course, needless to say, we must remove the catheter as soon as possible. And with that, I will also just like to offer your invitation if you're interested. We do a critical care nephrology review course every year, and the course schedule for 2026 is going to happen on 23rd and 24th May at the Academia Singapore General Hospital. And this is the QR code, and it will be available. If you scan the QR code, you'll have all details of the course. And if you're interested to register, you're most welcome, and we will love to host you in Singapore. With that, I thank you very much for your attention. And I know I have just finished on the dot, but I hope if there are some questions or things that there may be, we will.
Yes. So, yeah, thank you very much, Dr. Manish, for that very informative talk that ran spot on time on the vascular access. I actually honestly didn't know that there are so many things to know about the vascular access itself. So yes, so that was really good. So any questions from the audience?
I'm trying to see how I can unshare my. I think you are still seeing my screen, right? I think.
Yeah, it is. It is.
Why am I not able to? Are you able to share from your side? Then maybe you can unshare my screen.
Yeah. Vindivara, if you can unshare that. Okay, now it's not there anymore.
Okay.
Yeah.
Yeah.
Yeah. As I said, any questions from the audience? So, Dr. Manish, like, do you regularly change your lines after a period of time, or is it due to any problems in the line that you change it?
We don't necessarily change it. We don't do schedule change of lines unless we are thinking in terms of whether there's dysfunction of catheter, or if for any point of time we have realized that maybe the aseptic chain has been broken, right? So if we have a well-functioning catheter, in say if it's an IJ catheter, it has already been 7 days, 10 days, etc., but there is no signs of infection and it is functioning well, then we may just continue to keep that catheter. In fact, there are some studies that have shown, and in fact, even in the randomized, in systematic review, we showed that, of course, the duration they used there was much shorter, but there are studies that have shown that elective schedule change of catheter versus changing the catheter based on an indication there was really no major difference in their risk of infections. If we are in terms of femoral catheters, etc., sometimes we would change it in time, because if, say, the right IG became available and as the patient improves and we want to engage the patient more in terms of their physiotherapy or their mobility, right? And then as the patients are improving and their requirements are decreasing, then for femoral, we may choose to recite it to the IG if that happens.
Manisha, Dilshan here. Just adding to that question. Now, for example, if you have a patient who is having ongoing AKI and needing very prolonged dialysis in the ICU, so when would you think, now if you're expecting the patient's kidney recovery, it will take like maybe weeks, maybe or months. When would you consider putting a perm cat and removing your temporary line in those patients, and in a specific group of patients who need who you think will need prolonged dialysis?
Yeah, so that's a very good question, and I think it's practically very important, because a lot of times it is trying to prognosticate the trajectory of AKI. So even these patients may wean off from CRT, but it's still possible that they are dependent on intermittent dialysis. So usually for me, after 1 week, I'm beginning to think about it. By around the 10-day to 2 weeks period, if I see no meaningful or no evidence of any form of kidney recovery, and I see the trajectory of the illness is also such that I don't anticipate that all the insults have resolved or there will be some recovery, I'm already beginning to plan for a tunnel dialysis catheter. And actually, once a tunnel dialysis catheter goes in, if you compare the functioning of a tunnel versus a non-tunnel dialysis catheter, the tunnels ones definitely do much, much better. Our filter lives are definitely much better with well-positioned tunnel dialysis catheters. So first week, I'm okay, right? By the first week, end of first week to 10 days, you're kind of beginning to think. Around the 10-day mark, I'm already beginning to think and plan. Because if this guy is not going to, or this person is not going to recover in the next coming few days, then we are planning basically for insertion of a tunnel catheter. And if we get a good window in between, then we will just use that window to insert the tunnel
catheter. Thank you.
And and anybody may do it differently in your side, or is it something similar that you would do?
You mean the change of catheters? Yeah, so in our setting, the major problem is infection. So keeping it for long periods, I don't think it's kind of practical. So we take cultures, and then if with the slightest like suspicion of that it could be due to a catheter-related bloodstream infection, we just take it out. So I think the time period that we keep a line is much less compared to y'all. I'm not sure, but seems so. Yes, and we don't go for perm cats. 10 days you would consider perm cats, isn't it? But I don't know about Dilshan, but in my ICU, perm cats come much later. Yeah, so we kind of continue using the same lines, which might have to change the practice also at that point.
Yeah. No, when I say 10 days, I'm beginning to think and plan about it, because like you rightly pointed out, perm cats, even for us, they happen in our interventional nephrology suite, or the patient has to be wheeled to the nephrology suite. We don't do it bedside, right? So they have to go. So what you say is actually absolutely correct. When I say 10 days to 14 days is that planning has started, right? But actually the tunnel cat may happen maybe a week, and sometimes we have a day, we have planned, but 1 or 2 days prior to that, as always, what patients do, something happens, then their blood pressure goes down, their gas exchange worsens or whatever, then we have to reschedule it. But that is also the reason why we begin to plan that period of time, because we know that the the time interval between planning and actually getting the catheter in is long, and it can be very variable, right? But we are mentally preparing ourselves that, because at some point, even though we keep them and don't do very, schedule changes like day 5, day 7, day 10, but we also know we are not going to keep them indefinitely, right? Maybe after 2 weeks or like you rightly suggested, any slight fever or inflammatory markers going up, any suggestion of infection, then of course, if the line has been there already for 7 days, 10 days, definitely we will change it, right? But of course, in the absence of all of this, if it's functioning well, there's no signs of infection or anything. And if it's functioning, then I may not. Yeah, but what you say is absolutely correct. And I agree with that. Yeah.
And we also, thank you about that comment. We run into problems like the line seems to be perfectly placed, the X-ray is fine, but still it's causing problems when we are running the CRRT. It's the flow is not adequate, although when we check it, it's fine. But then when you connect it to the CRRT, it doesn't seem to be working. Do you recommend changing it at that moment, or do you do any, adjustments to the line so that it might work? What do you suggest that we do?
No, so this one in the past, we used to try to do all things we could to try and make that line. And especially it's very frustrating when you just put in a new line in the evening, and then in the night or the next morning you come and you realize 2 filters have gone just because the line didn't work or didn't get a good dialysis. So in this, so one is of course the 2 or 3 things we will ensure. So one is common ones would generally be the hydration status of this patient, right? If they are a bit hypovolemic and the veins are kind of collapsing around the ports of the catheter, which is commonly that happens, that would be one reason. 2 is, especially if you're using a shotgun catheter or these catheters, the arterial access port should be pointing medially towards the mediastinum, whether it's on the side, so that they are not abutting the wall of the vein, right? So these are 2 things that can be immediately ruled out. The third one, sometimes we find, is that when there are a lot of compartment pressures, there's a lot of competing pressure with the catheter, right? So especially patients who have significant lung disease, and because of their ventilation, the thoracic compartment pressures are very high, or they fluctuate a lot, or in femoral catheters, if they have abdominal compartment syndrome, etc., which is compromising the venous return, right? And that may actually impair the function of the catheters as well. The excursions, the respiratory excursion and changes in the compartment pressure, sometimes they compete with the pressure, because on one side, the veins are not filling or they are being sucked in, and the other side, the catheter is trying to suck the blood out, and they begin to fight. So those would be few things that we will try to kind of troubleshoot as best as we can. But if this is happening in the absence of all these things, then between trying to salvage that catheter, I will probably find it better to just change and resign the catheter, because you will end up more time and effort salvaging the catheter, interrupting your dialysis, of course, needless to say, waste of filters, than actually get a good dialysis in this type of situation. Yeah.
Thank you very much.
The other part, I think what you mentioned is also something that we also, sometimes, after you pour, we just do that suction test, you take a 10 ml syringe and it fills up in 2 seconds or 3 seconds, then your flow is adequate. But most of the times when you connect them to a CRT machine, right, it doesn't work that way. And especially there's changes in position, all that. So even though this is a good test to check the adequacy of flow at the bedside, but I noticed that in real life, sometimes it is not necessary that if you're getting a good flow on the thing, you will meet it well when the patient gets connected to the dialysis machine. So what your observation is what we observe as well. So it's good to know if Singapore or say Sri Lanka, I think we all
Manish, in that situation, would you change the ports, like, arterial venous? Would you change it and see accepting the some bit of recirculation?
Yeah, I mean, to be very honest, if we would do that, and I think that is one of the things when I went troubleshoot, that would be one of the things to do to troubleshoot. So then it would depend. So if these patients are on CRRT, and if by reversing, I am able to still run the CRT sort of uninterrupted without major alarms, and it is giving me a good adequate run. Okay, then I will look at what is the solute control, what is the acid-base control, what is the uremia control, what is the potassium control. And if it is running well, generally because CRT is a slow therapy that is given for a very long period of time, I know that I may have lost some efficiency because of recirculation, but I may try to compensate that a little bit by adjusting the effluent dose. Of course, that would mean that I'm using more CRT fluid and a greater CRT dose than is required for that patient, but at least it lets me run the circuit. If these patients are on intermittent dialysis, then sometimes the recirculation, if it's significant enough, you may realize that even with a good session of 4.5, 5 hours of dialysis, we may not get an adequate solute acid-base or potassium control. So in that type of situations, then I would probably, my threshold to change the catheter from reverse flow to resite it to a new site will actually be much, much lower than in this, than if it was, this patient was on CRRT. But having said that, there have been some studies that have shown that if with reverse flow, you are able to get a good flow of the catheter, without any change in, without any major alarms or interruption. So like, if I did normal flow and a blood flow of 150, 180 for an intermittent dialysis, my machine keeps alarming. Versus if I reverse the flow, but I can go up to a flow of 220, 250 mils per minute, right? So that kind of increase in the blood flow may offset that decrease in efficiency I will get because of recirculation, right? In which case, then probably it would be okay to continue with that. Though, strictly speaking, that is not something that is recommended, but I think practically we all know, in ICU, every catheter costs money, every insertion costs money, right? And then, of course, every time we insert, there is risk of complications, etc. So then, to me, that would become sort of a clinical judgment that if I'm doing that, but I'm getting a better blood flow and I'm managing to control their uremic, acid base, and electrolyte milieu adequately, then maybe I will persist with it. But if that is not, then my threshold will change will be lower. So I don't know whether that addresses the thing, but in my mental framework, that is how I will approach this kind of problem.
Thank you very much. Any other questions? Must be very late for you, isn't it? Must be around midnight now.
Yeah, going to be, but it's okay. I'm very glad whenever I do this kind of interactive session, because it's to me, it's always learning both ways, right? I mean, I share what we do here, but when I speak to people on the other side, I also learn so much because every part is different. Challenges of every part are very different. So I thoroughly enjoy this.
So I don't think there are any more questions. So I would like to thank you again for accepting our invitation, and at this late time you have opted to talk to us and explain much of the problems that we have, and have a good conversation and interact with us. So we really appreciate it. And so on behalf of the Ceylon College of Critical Care Specialists, I would really like to thank you again, and hope that maybe we can have more sessions like this in the future, if it's okay with you. So with that, yeah.
Thank you. Thanks very much. Thank you everybody for this very kind invitation and this opportunity to share with you all. And I will be more than happy if we have future opportunities to collaborate. I mean, for these kind of sessions, I would love that. Thank you very much. and wish you all a very, very good night.
Yeah. So for all the participants, thank you very much for taking part, and so hope to meet you again with another update very soon. So thank you everyone, and good night.
Good night. Bye-bye.
Bye-bye.